Thanks for having me today. It's really wonderful to be here and really a pleasure to be able to talk about a subject that I've been thinking about quite a bit. It's something that we really seriously need to address and acknowledge. It'll make the difference in a lot of people's lives. So I have no obligations to the big pharmaceutical companies, thank God. I try to avoid them. But my topic today is longevity. Longevity has improved over the past number of years. In the 1800s, average life expectancy was, 39 to 40 years old. And in 2020, it jumped up to almost 80. But since that time, it started to decline. And there's been a lot of reasons for that. But when we will talk about those coming up. I want to give a shout out to Peter Attia. He is a physician that is a longevity expert. And he's had this book Outlive on the New York Times best-selling list for almost a year now. It's very valuable not only to our patients, but also to ourselves. There's some good antidotes there and really kind of gives you some sort of insight on what it takes to live a long and healthy life. He talks about longevity as being long existence or service. In the early days, in the 1900s, people that died from what he called a fast death. That was from accidents, injuries, infectious disease before their antibiotics. But in present times, and we're now looking at the major causes of death are slow, chronic diseases. So there's two components to longevity. One is how long are we going to live, which is your lifespan. But even more important is how well we're going to live. What is our health span? So some of the anecdotes start with this lovely man, Henry Allenham. He was a British veteran in World War One. He lived to 113 years old, and he attributed his longevity to cigarettes, whiskey, and wild women. And you can tell why he was so popular. He is really a handsome guy. You can tell by that. The next person is Jeanette Clement, who's French. She's the oldest person ever to live on record. She rode her bike up to age 100, kept smoking until age 117, and died 5 years later at 122. Probably shouldn't have quit smoking, I imagine. But anyway, her one comment that was funny is that I've had only one wrinkle in my life and I'm sitting on it. If aliens came down to Earth and they looked at the centenarians, they would have concluded that longevity on Earth was really achieved by eating the Grand Slam breakfast at Denny's, having some Jim Beam to wash it down with a good cigar. Also in the book, Dr. Attia describes the four horsemen, the causes of death: cardiovascular disease, cancer, dementia, and diabetes, the four horsemen. I, of course, am cardiovascular and will be addressing this formally. Cardiovascular disease is still very dangerous. It's a ticking time bomb. All of us are affected, either our family, our friends. There's probably about 900,000 deaths in the US in 2019, and there's still a heart attack just about every 40 seconds in the US. However, heart attack incidents were definitely on the rise since 2021. It's still the number one cause of death. Heart disease, heart failure up 38%, heart disease in general up 8.5. From 2011 to 2016, we've seen a deterioration. And the other thing that is very disturbing is now there's no age bar when it comes to people having a heart attack or a stroke. I'd like to break down some of the generations that are still here on the planet. There's the traditionalists if you're between 80 and 100. They're the baby boomers if you're between 60 and 80. Gen X if you're between 40 and 60. And millennials, which are also called the Y generation, are between 20 and 40. And then Gen Z, who are the young people who I'm sure none of them are watching today. Traditionalists, they're about 80 to 100 years old. There's 30 million, 10% of the population. Still a lot of very active people in this generation. So the easy way to identify these people is that their emails are AOL.com. You can tell who they are. Thing is, they definitely avoided fast death. They lived longer than their parents' generation, but they did love to party. You can see that the smoking and drinking that was seen in the movies and all didn't lead to a very long lifetime. The baby boomers is the 60 to 80-year-olds, about 70 million, 20% of the population. It's been said that they're the largest, best educated, and wealthiest generation in American history. They're identified by the flower power generation and the hippies, but you can tell them by their email. They're either an MSN.com or they're a Hotmail.com. Now, Gen X, if you're between 40 and 60, it's a large percent of the population, about 19%. A lot of positive attributes. They're expert do-yourselfers, sort of a dress-down lifestyle, tech savvy but not text dependent. They still remember the days of dial-up and having to wait and reboot your computer. Very independent, synonymous with punk and grunge music. However, the disturbing thing is that the heart attack, stroke, and death rate in Generation X has almost doubled in the last 20 years. And it could be attributed to a lot of lifestyle type of changes, junk food, video games, sedentary lifestyle, which obviously leads to high blood pressure, high cholesterol, and diabetes. Plus, there's a high stress level in this group. They have to take care of their children and their parents at times, and especially for women who could be the primary caretakers of their families, but also full time employees. The millennials, my kids' generation, between 20 and 40, adventurous, more likely to study abroad, much more tech savvy. They're concerned about global issues, and you can tell them by their email, which is gmail.com. Again, disturbing also, however, that hypertension is growing about 20% in this age group in this period of time. And it's more common than the Gen Xers at that same period of time. There's also much more obesity than in previous generations seen. What we really are seeing is that the Gen X's and the millennials may be the first generation in modern times not to outlive their parents. And there's reasons for this. Atherosclerosis is the key to cardiovascular disease. And what's very disturbing is that this probably says it all. This pizza looks just about the same as the diseased aorta. So, in terms of you are what you eat, it's a very scary kind of a sight that we're seeing here. So, the most important factor here is coronary disease, of course. There's different degrees of coronary artery disease, plaque deposition in the intima, LDL cholesterol combined with calcium, which hardens your arteries. Is your healthy artery, you can have mild deposits that can progress to moderate and to severe. And then you get to the point where it's really dangerous. You can have a high grade lesion of your left anterior descending artery, which is the widowmaker, and definitely not a good thing to have. Atherosclerosis is just not a disease of older generations. Your first visible, this is a fatty streak, and you first can see this in developed countries in children over 10 years old. The majority have this. And into adolescence, you can see fatty streaks even in the coronary arteries. They had a study in 1953 of the Korean soldiers that died during this war that they autopsied, and 77% of them had visible signs of atherosclerosis in the coronary arteries. So this is something that starts early and becomes really silent and not apparent until much later along in life. So basically, we have a time bomb. Despite major advances in treating cardiovascular disease, it's still one of the overwhelming causes of death. And the reason is we are not adequately diagnosing or adequately treating the modifiable risk factors for coronary artery disease really until a person has an event for the most part. We need to make this diagnosis early and we need to be aggressive to treat these things that we can prevent. Now, there's been a lot of ways to assess cardiovascular risk, ranging from the Framingham studies early on up to the most recent one, which is the ACC risk calculator. But a lot of this is based on subjective and surrogate endpoints. They're basically the same combination of risk factors, and they have a lot of flaws. There's a high rate of false positive and positive negatives. A simple lipid panel, you could have a really high LDL, but not necessarily, have atherosclerosis. The thing is now we have a much more accurate tool that can help us make this determination. This is a coronary artery calcium score. It's a simple x-ray. It takes about 10 minutes. It's a CT, and you can tell immediately if there's the presence of coronary artery disease. Here's a clear, nothing, zero. This is a mild plaque. It becomes moderate and then becomes severe. Having a positive coronary artery score is very dangerous. Even in young individuals, there was a study between the ages of 30 and 40. There was an increased risk of fatal heart attack and strokes in a 12-year period. Even a score of 100 was associated with early death. So even with low scores, if it's positive on the CT, they have an elevated risk of cardiovascular disease. Here's a slide that talks about the prevalence. Here's a zero calcium score. If you're between 30 and 40, 78% of the people have a zero score. But then all these people have positive scores, and 40 to 49 the same sort of way. Only 60% have a zero score. Once you get into the calcium score of 1 to 100, you start developing evidence of significant disease, as you can see here. A zero score, the rate of congestive heart failure and diseases are low, cardiovascular disease. But as you get higher and higher, all cause mortality goes up as the progression of arteries. So it's a very dangerous situation to be in. So, how do we achieve longevity? If 20% of the men over 40 and women over 50 have coronary artery disease, they're dying too young, and we're seeing this evident. How do we approach it? We have to be risk factor profilers. We have to recognize the cardiovascular risk factors. There's non-modifiable age, family history, and gender. Sometimes we wish we could modify those, but we can't. We're stuck with this. But If we look at the modifiable risk factors, these are something we have control of and something that we can act upon. This is hypertension, hyperlipidemia, diabetes, obesity, tobacco use, and sedentary lifestyle. Hypertension: 100 million people in the United States have high blood pressure. Most of them, or a lot of them, are not well controlled, and a lot of people are not even diagnosed, and it is a major cause of heart attack and stroke. Hyperlipidemia: about 1 in 3 people have hyperlipidemia, and that increases your risk, obviously. Diabetes nearly doubles a person's risk of early death, most likely due to heart attack and stroke, the seventh leading cause of death globally, which is about 11% of the population. 8.5 million of those are undiagnosed. Obesity increases the patient's risk of up to 28%, even in people who may have healthy blood pressure, blood sugar, and cholesterol. For each increase in BMI, you get a 5% increase, especially in young people. Early cardiac death is common. Tobacco use: this is something that we all know about. This is something that's been promoted for years for economic reasons. A man will lose about 14 years of his life, and a woman 15 years of the life from smoking. More young cigarette smokers, a huge problem that really leads to a variety of problems. And this is just a short list of all the things that you can get from tobacco use. So basically, when you look at things are progressing throughout the generations, we're looking that we may be in a deterioration. Now, there is a good news. We do have a solution. We have the problem, we have the solution, and our goal will be to get success. Treating modifiable risk factors worse. If you treat it effectively, you can diffuse this time bomb. If you treat high blood pressure, your risk of heart attack and stroke can be reduced by 20%, 30% per stroke, heart attacks by 20, and you can reduce dementia, heart failure, and mortality, obviously. Lowering bad cholesterol has been shown in multiple clinical trials to show that not only is there stabilization of plaque, but there's a regression of plaque with early lipid therapy. Diabetes treatment has shown to reduce cardiovascular events. Losing weight and exercising have all been effective mechanisms. Lowering LDL works. These are studies that were done at the Cleveland Clinic. Dr. Nissen would do coronary ultrasounds of these people. And they have showed if you can get the LDL to less than 70, not only do you prevent the plaque from growing, but you also get regression of plaque. And when I was doing interventional cardiology, we would do angiograms on people that we put stents in previously. There would be other lesions, 50 to 60% lesions. We'd have to do the angiogram maybe a few years later, and we saw the disappearing, visual disappearance of lesions that we had seen. So it's a very powerful tool. So in terms of cardiovascular wellness, risk factor profile, my recommendation is if you have a guy over 40 or a woman over 50 to get a calcium score. I think that's one of the screening things that should be adopted. If it's negative, you really just need diet and exercise and repeat the calcium score every 5 years. You have a very good prognosis and just really need to focus on lifestyle changes. If you are positive, however, that is an alarm and something that should be acted upon right away. I would go then to an ischemic workup, a stress test, exercise, echo. If it's negative, then you have coronary artery disease without ischemia. Your goal then is to get your LDL less than 70. There's ways you start with the statin, you can add something like Zetia, plus or minus the PCSKA, and do an ischemic evaluation every 2 years. If the ischemic workup is positive, then a cardiologist needs to get involved for further evaluation. In terms of hypertension, I saw this in the New York Times a couple of years ago. This is what hypertension looks like. He looks like a millennial. He's actually a Gen X that made a lot of bad lifestyle decisions. Bad day for him is getting his bypass surgery, obviously. But hypertension is something that needs to be addressed aggressively. These are some of the guidelines that look confusing overall, but the bottom line is you want your blood pressure to be less than 130. People with blood pressure less than 130 live far longer than people with higher blood pressures, even 140, 150, 160. And the bottom line is that's where you want to be. One of the major things in blood pressure control is getting your patient involved. It makes a tremendous difference and increases the chances exponentially. This is one of my patients that amazes me. He's obviously a smart guy. He's a JPL scientist, and he really showed that he really was keeping track of blood pressure. And he's successful. The majority of these are acceptable. So for hypertension, these are just pretty much algorithms that everybody uses. Everybody has their own way of approaching it. If there's no kidney disease, which you want to eliminate, then you make the decision. You either go with, if you have no edema, ARB, ACE ARB, add calcium blockers, add diuretics if you need to. If you do have edema, it's good to start with a diuretic, maybe add these things later. But the thing to understand is that The response to treatment is variable. 30% overall are going to react to be treated well with one drug. That's why the current recommendations say that you probably should start with two drugs, either ACE ARB diuretic, ACE ARB calcium blocker, and then you get about 50 to 60% achievement. 70 to 80% can be achieved with three drugs. But then there's another 20% that are very poor to control. And has to be an indication that something else may be going on. These people can be resistant. They have resistant causes of hypertension. And there's some very common ones. Sleep apnea. These people are usually hyperaldo. You can tell they have low Ks, they have really high blood pressure. They really respond to spironolactone type of medication. Renal disease is obvious. They have higher creatinines. Primary hyperaldo, these are like Conn's disease, which is an adrenal adenoma, or you could have just some diffuse hyperplasia. These are usually told by low potassiums, high to control blood pressure. Renal artery stenosis is more common than you would think. Good tip if you have this is that if you give an ACE inhibitor or an ARB, you get a bump in creatinine. Or if you do an ultrasound of the kidneys, there's a difference in size in the kidneys. The one being supplied by renal artery stenosis will be the one that's atrophied. And then obviously oral contraceptives. The uncommon ones, FIOs. I've been looking for FIOs for probably 40 years. I'll let you guys know when I find one. Still haven't found one. Other things, Cushing disease, parathyroid, all these other things are stuff that you probably won't see. Diabetes. Diabetes is just very frustrating for all of us. It's very difficult to treat. It's unclear which regimen is most effective. But I think there's been a big change in the way we look at diabetes nowadays. I think we're really see that we have agents that have cardiac benefits, and I think we are starting to gear towards that. There's two groups that we're looking at, these SGLT2 inhibitors like Jardiance, Farxiga. They lower the hemoglobin A1C and the weight loss, but they've also been shown to reduce rates of cardiovascular events. In their study, they decreased the rate of hospital admissions by 30%, especially in low EFs, and reduce worsening of renal failure. The other novel group are these glucagon agonists. There's the GLP-1, GIP, and GCGR. What they do is they stimulate insulin release, they inhibit glucagon release, lower the sugar, and they also have the added effect is that they lower appetite and then they increase energy expenditure. And I'll go back to those in a second. Weight loss is something that is not rocket science. It's easy to lose weight, theoretically easy. If you have a basal metabolic energy of 2,000 calories a day, which we mostly have, if you exercise 30 minutes, 5 days a week, you can burn about 300 extra calories. So a total of 2,300 calories. If you limit yourself or calorie restrict yourself to an 1,800 calorie diet, you will be a negative 500 calories. And if you do that for a week, you will lose a pound. So for every 3,500 calories per week, you lose 1 pound. And that works. The problem is nobody wants to do it. We all love food. We have an endless supply of it. We are constantly reminded of it. And a lot of this stuff is actually pretty good. If you look at In N Out, it's very popular. We have one by our house, and there's usually a line that's way long just to even to get in here to get this stuff. I feel like some days of going down the line and handing out my business cards to these people to help them. So diets are very popular. As you can see, there's a tremendous amount of diets that are available and always have been. They're the best-selling books that are out. 5 million diet books were sold in last year. A lot of them have short-term results, but few have proven long success because people aren't going to change what they do. There's been a lot of ways to reduce a person's appetite and hunger. In the olden days, they would actually use amphetamines, not recommended by the FDA, of course, because of all the different side effects. But these are our medications that have all been tried by the FDA for either short term or long term use. And again, none of these have proven to be major success. Bariatric surgery, which is something that is helpful, has a dramatic loss of weight. And in many of the people that go through this, their diabetes will just disappear. And it's really good to see. It's a difficult thing to go through. I mean, this is something that has to be taken seriously. Something that is really, though, interesting and something that's coming up in the future is here's a recent study in the New England Journal that this new medication, which actually has a triple hormone receptor agonist effect, it's not available, but these people lost a tremendous amount of weight in 48 weeks. And this loss of weight and this type of medication was shown also in the New England Journal to reduce the risk of cardiovascular death, non fatal heart attacks, and stroke significantly in the people that underwent this therapy. Now, these are the GLPs and the GLP-1s and GIPs. These are the ones that are making this big difference. If you take Ozempic, for example, it lowers your hemoglobin A1C by about 0.78 and a 15% weight loss in 48 weeks, which is incredibly a lot. And this new drug lost 24% of body weight, or almost 60 pounds in the study that I had shown you in the New England Journal. So this is something that we should really think is a very powerful tool, and trying to get people to get to this point is very important to us. Weight loss could be the second most powerful tool for longevity. Aerobic exercise, probably the most important tool. Let me go ahead and show you this.
You could say Nat Hines is the definition of a gym rat.
The only way to keep my body apt to this is to keep exercising.
He's been a regular at the 5 Point Center for Active Adults for years. When the facility had to temporarily close due to the pandemic, Mr. Hines continued his workouts at his apartment complex, but it just wasn't the same. As you can imagine, he was more than excited about his first day back at the gym.
It feels good. Feels good.
So why is the center so important to him? Well, Mr. Hines is 100 years old, and he contends the regular workouts have helped him reach his life milestone.
If I don't exercise, I say, oh, everybody may not be that way. You start having little aches and pains here and there.
Plus, there's the people. He's become friends with the staff and with fellow exercise enthusiasts. Whether it's logging miles on the treadmill or lifting weights, Mr. Hines jokingly told us nothing will stop him from his weekly workouts at the center.
You may have to, you may have to put some oil on those bones a little bit, keep them going.
And we'll be cheering him on every step of the way.
This is just one person that's kind of been a real inspiration to me and motivator in terms of my approach to health. Mr. Hines is a 100-year-old guy. He exercises every day. He does an hour workout every day. And it's really a nice video to see. 150 minutes of continuous aerobic exercise, which is about 30 minutes to 5 days a week, has been shown in multiple meta-analyses to reduce hypertension, diabetes, hyperlipidemia, dementia, and of course, mortality. And that's something that if you really can get our patients to do that, they will thank you. And the people that do it really appreciate it. One of the things we want to do is talk about why isn't the coronary artery calcium score a routine test? Basically, there's really not a false positive calcium score. If you have calcium in your arteries, you have coronary disease, whether it be mild, moderate, or severe, it's something going to happen. When you compare it to the standard ones that are usually tested, the PSA test is false about 12% of the time, which usually results in a biopsy, which isn't a great day for most of us. Mammogram, many of us know that is falsely positive many times, involving further workup, which causes a lot of stress and anxiety, but obviously is something that's needed. Colonoscopy, about 4% of colonoscopies are positive for cancer out of the number that are done. And disturbing to me was this recent article that showed that there was no difference in lifespan. And when they looked at it for 9 years in the mammography, colonoscopy, prostate exams, and the computerized tomography for smokers. But aggressive treatment of modifiable risk factors for coronary disease, which we've been talking about throughout this time, has been clearly shown. And if you can do all these different aspects, you will be successful. So why it's not available standardly and why insurance doesn't cover it is unclear to me. But I think we should really consider that using the coronary artery calcium score in individuals in early adulthood so they can make proper decisions about aggressive treatment and people that need to be treated and not. So basically, we have the tools that we have to promote survival. We want to keep your systolic blood pressure less than 130. You want your LDL less than 70, your BMI less than 25, hemoglobin A1C 6.5, aerobic exercise, and not smoking. That will promote longevity. What I like to do with my people or try to create this scorecard that lists all the different things that they need to be focusing on and the advice to give to them. And it's been very successful. Getting people involved in their treatment is the most important thing. Our main mission in taking care of all these people is that we want to knock heart attacks out of the top 10, heart attacks and strokes, number 1 and number 5. And if we can do that early on, we can make a tremendous difference in what we do for our patients. One of the things I didn't focus on was stroke. We talked about heart attack and stroke. And when you look at stroke, basically all the same risks: hypertension, hyperlipidemia, diabetes, carotid disease, atherosclerosis. But one thing we haven't covered, which is probably one of the more important since a third of strokes are due to this, is atrial fibrillation. And this is a cult. I mean, in my career, people would come in with a new stroke and they were in AFib, never had a history of it before. And one of the good things about stroke from AFib, it's due from thrombus. And when you embolize, you can do an intervention where you could actually extract the thrombus. It has a better response to PPA. So making the diagnosis of AFib, when you have these people coming in complaining of palpitations and they're in a high risk group, it's really something to focus on and take them seriously. Evaluating with monitors, make sure their LV function is proper and all that sort of thing. So anyway, we don't want to miss out. We want longevity. These are my grandkids. I want to be there for healthy longevity and see all their milestones and hopefully see great grandkids in the future. And I think if we focus on all these modifiable risk factors in our patients, and make the diagnosis and aggressively treat atherosclerosis, we will achieve that. And I think in the next years to come, if we aggressively do this, we will note a big difference in the outcomes of people in the future.
If you are at risk for a heart attack or stroke, it is essential that you are thoroughly evaluated as soon as possible. Contact the cardiovascular wellness expert at 888-521-1101 to set up a prompt appointment. It could be the difference between life and death. Call us if you want to live. For more information, go to thecvwellnessexpert.com.